Hi, greetings. I'm Dr. Neha Gupta, and I'm thrilled and excited to be part of this first SIDS ISCCM collaboration. And I'm going to discuss regarding navigating tuberculosis management in the ICU. What are the various challenges and solutions? So, as we all know that India has the largest burden of TB patients in the world, and we account for 27% of the TB cases. Besides this, many patients present in the ICU. And there is also emergence of drug resistance with MDR-TB close to 3% among the new cases and 12% among the previously treated cases. All this adds to the complexity and to the increasing mortality. But what are the challenges, especially related to the patients who are presenting with tuberculosis in the ICU? First is related to the diagnosis, which is often delayed because of the lack of clinical suspicion, as many patients present with MODS or sepsis, which takes the forefront. The investigations, how do we perform the right test for the early diagnosis? And most importantly, how do we start that anti-TB regime, especially if the patient is having liver or kidney dysfunction? What should be the dose modifications and also drug interactions, especially with rifampicin? These have to be kept in mind in patients with tuberculosis in the ICU. And the importance of infection control, which is paramount in order to prevent the spread of the TB among the ICU patients. So let's begin the first one, which is related to challenges in the diagnosis of tuberculosis. This is a 52-year-old gentleman with diabetes and hypertension. He had headache and vomiting for 15 days, and then he developed fever for 5 days, presented with altered sensorium in the ICU, had Kernicks positive. Peripheral WBC count was 12,500. And as we can see here, there is this leptomeningeal enhancement, which is seen on the MRI. So CSF was performed, which showed that there is neutrophilic predominant CSF pleocytosis with increase in the proteins as well as CSF hypoglycoria. So here the peripheral, the ink was performed, the CSF grad was negative, and the CSF expert MTB was not done, and he was empirically started on ceftriaxone and anti-TB drugs, and an ID reference was sought. So what do we do in this patient? Should we continue with ceftriaxone and vancomycin or continue with ceftriaxone, vancomycin along with ATT? Vancomycin is added because he had peripheral leukocytosis, probably suggested towards a bacterial infection. Anti-TB drugs, or should we give ceftriaxone, vancomycin, anti-TB acyclovir? Besides this, many a times I think meropenem or even doxycycline can also be considered in patients who are presenting with meningoencephalitis in the ICU. So, is there any clinical prediction rule or a criteria which can help in the diagnosis of tuberculosis while we are awaiting the test results? So, there is this modified Thwaites criteria, which consists of age less than 35, peripheral WBC of less than 15,000, a CSF WBC count of less than 750, and a CSF neutrophil count of less than 90%. Now, each of this is given a score of 0. The fifth parameter, which is history taking, a history of illness more than 5 days, is given a score of -5. So adding all this, if the total score is 4 or less, then it is suggestive of TB meningitis and differentiates the patients with altered sensorium or meningoencephalitis from bacterial meningitis with a very good sensitivity of 99%, and it has a specificity of close to 80% as well. So this is a modified Thwaites criteria which can be used by the intensivist or by the infectious diseases physicians for making the early clinical diagnosis and differentiating patients from bacterial meningitis. But again, this is history taking, which has to be emphasized because that can completely change the scores. So when do we suspect TB in the ICU? It is in a patient who is presenting with headache, vomiting, seizures, altered sensorium. Usually, patients with TB will have normal WBC count, but if they're presenting in the ICU, they can also have elevated WBC, which can be because of secondary bacterial infections. Many patients with CNS tuberculosis may also have lung involvement, maybe close to 25%, may have the lung manifestations as well. When a patient is presenting with breathlessness, hemoptysis, persistent cough, especially if it is immunocompromised patient, transplant recipient, patients on steroids, immunosuppression, then besides considering the diagnosis of pneumonia, TB should also be considered. Of course, we should investigate to rule out other etiologies like PCP, Cryptococcus, Nocardia, Aspergillus, as well as CMV. Sometimes patients may present with the GI manifestations, like patients with ileocecal tuberculosis may present with sepsis, and also patients may have Addison's disease and can present with fatigue and hypotension. The general symptoms of tuberculosis includes a history of fever, night sweats, weight loss more than 2 weeks, and more importantly, a history of contact with a patient with TB is extremely important and should be inquired. Now, after the initial evaluation, the clinical evaluation, it's important to send the right investigations for the early diagnosis, and which is a battery of tests including radiology, biochemistry, and microbiology. And arriving at a diagnosis is interpretation and integration of all of these with the clinical correlation. So, patient who's presenting with pulmonary findings, sputum or a bowel, should be sent for expert MTB. But remember that even if the expert MTB is negative, even in a patient with miliary TB, it could still be tuberculosis because the sensitivity is only 40%. Now, coming to patients who are presenting with CNS manifestations, the um, the way we send the CSF samples is important. The middle portion has to be sent for the microbiology, the first portion for the chemistry, and the last for the hematology. The CSF cultures should be sent for the AFB in the right volume, and at least 5 ml should be sent. We need to also send it to rule out other etiologies like the blood cultures. The CSF can be sent in the blood culture bottles for ruling out other bacterial etiologies. And the film array panel, which is the meningitis encephalitis panel, which commonly detects the 14 common pathogens, does not detect TB. So CSF should be sent for the expert MTB RIF or the expert MTB RIF Ultra, which can help in a faster diagnosis. And in fact, the molecular assays have been the game changers in the diagnosis of tuberculosis. The traditional methods like the microscopy are less sensitive, but the molecular assays are much more sensitive, and they can help in the diagnosis within just 2 hours of initiation of the test. Besides, they can also help us in determining the rifampicin susceptibility or resistance. The expert MTB does not detect isoniazid monoresistance, so this needs to be kept in mind. We can also send the samples for the CSF for pyrosequencing. And pyrosequencing not just detects MTB, it also tells us about the mutations. So the CAT-G mutation as well as the INAG mutation for the isoniazid can help us in choosing our anti-TB regime. If suppose there's a CAT-G mutation which is detected here, which makes that we cannot use high dose isoniazid, and it is the ethionamide which has to be used for the treatment of the MDR-TB regime. Besides, we can also detect resistance mutations to the rifampicin, kanamycin, as well as to the fluoroquinolones with the Gyrase. Now, in the same patient who had presented with meningoencephalitis, the CSF culture had grown AFB, and it was identified with the help of this rapid MPT64 antigen test, which identified as the MTB complex. Now, once we have a clinical suspicion, we have sent the appropriate test. We need to start the patient on the appropriate anti-TB regimes. So what should we start? This will depend upon whether the patient is likely to have a susceptible tuberculosis, or is it a drug-resistant TB. Now, this will depend again among for the history. So the prior drug history and also the response to therapy is important, because patients may present in the ICU sometimes with even paradoxical response. So here, if the patient has not received any prior treatment and has a normal kidney or liver function, then the initial therapy has to be the standard first-line drugs, which includes isoniazid, rifampicin, pyrazinamide, and ethambutol. And this is usually continued for 2 months. In the continuation phase, we switch to the 4 months of 3 drug therapy, which is isoniazid, rifampicin, and ethambutol, and not just 2 drugs, because we have a high INH monoresistance in our country to the tune of 10 to 15%. And as per WHO, if the isoniazid monoresistance is more than 7, then we need to give HRE during the continuation phase. Now, if it is a MDR TB or drug-resistant tuberculosis, then treatment has to be modified for the MDR TB, and the options in the ICU will include a second-line injectable fluoroquinolone, meropenem at a high dose of 2 grams 8 hourly. We can also choose clofazimine, linezolid, which can be given IV linezolid 600 milligrams OD, and it's not twice daily. The other options include monopass, ethnomide, cycloserine. Now we have to tailor the therapy based on the kidney or the liver function of the patient. We can also start with bedaquiline as a bedaquiline if it is available. The doses for the anti-TB have to be weight-based, so the weight of the patient should be assessed, and isoniazid is usually recommended for adults at 5 milligrams per kg, usually 300 milligrams, rifampicin at 10 milligrams per kg, 600 milligrams. Pyrazinamide is usually around 25 to 35, so maximum dose up till 2 grams per day can be also used. Ethambutol again 15 to 25 milligrams per kg, and a higher dose is preferable for TB meningitis because of the limited penetration of the ethambutol into the CSF or into the CSF. So the initial therapy is HRZE, which is a daily therapy, and in case the patient has renal creatinine dysfunction or reduced creatinine clearance of less than 30, then renal dose modifications are recommended for pyrazinamide, ethambutol, as well as for the aminoglycosides. Remember that isoniazid, rifampicin, as well as ethnomide do not require any renal dose modification. Among the anti-TB drugs for the MDR-TB, cycloserine and monopass also need renal dose modification as they have significant urinary excretion. What if the patient has got liver dysfunction with a SGPT of more than 5? So this is severe, and patients who are getting admitted into the ICU will have a severe TB as well, which can be infectious. So here we should not be stopping the drugs. It has to be drugs which are safe for the liver. So stop all the hepatotoxic drugs, which includes isoniazid, rifampicin, as well as pyrazinamide, and choose non-hepatotoxic drugs including ethambutol, levofloxacin, aminoglycosides based on the kidney function, meropenem, which can be also used, and linezolid and cycloserine. And then regular monitoring every 5 days can be performed to check the response. We can reinitiate if the SGPT is less than 2 times the upper limit of normal. Start with rifampicin, then isoniazid, and then with pyrazinamide. And avoid pyrazinamide if the SGPT was more than 200. Now, interactions are important. Remember, rifampicin and fluoroquinolone have got interaction. Rifampicin reduces the moxifloxacin concentration by 30%. And other interactions of rifampicin with anti-epileptics, antifungal, especially with fluconazole, voriconazole, posaconazole, isavuconazole should be considered. Antiarrhythmics as well as anticoagulants as well as immunosuppressants like tacrolimus should also be monitored, and the doses have to be optimized accordingly. Coming to infection control, it is very important. Airborne precautions, staff has to be trained, monitored. Remember, all this is important, and early diagnosis will definitely help in the better containment. So TB in the ICU is a complex but manageable with an aggressive diagnostic approach and personalized treatment. And success will come with working together with a long-term strategy. And I hope to have a very fruitful collaboration between SIDS as well as ISCSM. Thank you so much. This is one of the this is an initiative, and you can scan it to see more details regarding the TB treatment. Thank you so much.